Okay, so we're going to talk now about the stages of labor. The first stage of labor is from the onset of labor until full dilation. So we talk about stage 1 labor. It's from the time that labor is established. Those contractions started, the person recognized this is actually labor, but whatever time labor, the onset of labor until full dilation. Okay. And it's kind of broken up into phases. This is the longest stage of labor, almost always. It can last 12 to 24 hours without intervention. The average is shorter than that because we tend to give meds to speed it up if it's taking longer now. But it can last 12 to 24 hours without intervention, without being abnormal. Protracted labors that last longer than that do happen. Frequently they're due to some kind of complication, and they can cause complications. So onset of labor to full dilation. First we talk about latent or early labor. This may be until around 4 to 6 centimeters. There's kind of a changeover between early and active labor that most people are going to notice. And we can put a centimeter dilation on it, but it actually varies. I've seen people move from early to latent labor at 2 centimeters. I've seen them in labor that looks very latent and just gradually, slowly dilating, and then maybe at 7 or 8 centimeters get active. So don't get stuck on how many centimeters before they're in active labor. Just be aware that generally the first part takes the longest. Okay. Dilation is slower at first. They may be effacing before they're dilating. So they're having contractions or having contractions. They might be 2 centimeters. The next exam, they're still 2 centimeters. But if you pay attention to the rest of that exam, the effacement may be changing. The descent is gradual. The baby is still gradually getting lower. Okay, so that station number should be changing also. The contractions are mild to moderate. They may be every 5 or 10 minutes or even further apart. They usually last less than a minute. They gradually get stronger, longer, and closer together. Usually, I want you to think about emotional signposts in labor. Okay, we can talk about what's going on physically, but emotionally, you can often judge what's going on in labor by a patient's emotional responses. So a typical emotional response in latent labor or early labor, they're excited, they're probably anxious, they're talkative. This is when they may have a bunch of people in the room, they're having a party, they may be playing cards, playing games, watching a movie, whatever, because labor does not take all of their energy and focus. Okay. Active labor, when those contractions get hard enough that it really is taking all of that person's energy and focus to deal with it, then they've moved into active labor. And that can be, depending on who you talk to, between 4 and 6 centimeters until complete dilation. Effacement usually completes sometime during this time, so they may be mostly effaced by the time they get here, or they may still be doing some effacement. They dilate faster during active labor. So this may be like 1 or 2 centimeters, or a centimeter every 1 or 2 hours. Okay. Descent is still gradual until near the end. And near the end, it may be really fast. So they're still just gradually getting lower and lower. Toward the end, it may be really fast. The baby moves down very quickly. The contractions are moderate to strong. And over this time period, they get stronger, closer together, and longer. Okay. They get more painful. If a mother's planning an epidural, they usually go ahead and get it at this point. If they're not planning an epidural, they may wait until they're almost completely dilated. And in that last little bit of active labor, they may change their minds. Okay. So if they're planning an epidural, this is usually the time they request it. Epidural administration guidelines vary by practitioner and by facility. There are facilities that don't allow an epidural till 4 centimeters. I don't know that there's really research behind to back that, but you need to know your facility's policy and the providers, what providers working that day. In this part of labor, they're more focused, and especially during a contraction, that's all they can do. So this person might still be carrying on a conversation, probably doesn't want to party in the room at this point, but they might be carrying on a conversation and then hold on a minute, breathe through that contraction and go back to what they're doing. Now, at the end of active labor, most women have this little sub phase. They used to call it transition. It's not in the books anymore, but it's recognizable. If they're not medicated, especially, you're going to notice this. This is usually between around 7 or 8 and full dilation. So the last couple of centimeters. Dilation is usually more rapid during this time. This phase is usually the shortest and the most intense. Descent is more rapid. And when the baby descends and starts putting pressure on the pelvic floor, then it can trigger a lot of other sensations. The contractions are firm. They're every 1 or 2 minutes. They last 60 to 90 seconds. Sometimes they double up. So it feels like a contraction is going down and another one hits. The pain is generally the most intense. Women who did not plan an epidural may change their mind at this point. Sometimes other physical symptoms, they're actually very common. They may have shaking, cramping, nausea, vomiting, belching, passing gas. Sometimes, especially if the fetus is very low, they may start to have involuntary pushing or start feeling an urge to push. If the cervix is not fully dilated, and especially if it's still pretty tight, if it's not fully dilated and it's not really loose, then pushing may actually cause it to swell. So we discourage pushing until they're fully dilated. In this time, it's really common to feel stressed, anxious, overwhelmed. Women in this phase are very suggestible. Sometimes they have a hard time maintaining focus. This is the most common time when people say, I'm done, I quit, can't do this. I don't want to do this anymore. So they might decide to, I'm going to take out my IV, I'm going to go home. So that's not an uncommon response. So at this point, someone needs to be supporting the patient through that stage of labor, through that phase. That's the end of stage 1. Okay, stage 2 is from full dilation, full cervical dilation, until the baby is completely born. So cervical dilation, baby out. A lot of times in stage 2, that mom or that person may feel a renewed energy. They've been exhausted, overwhelmed, and then once the cervix is dilated, some of those sensations get better, and they may actually get a kind of a second wind. They may also be afraid of pushing, or the new sensations of pushing that can be very intense may be overwhelming. There are sometimes 2 phases of the second stage. In the latent phase, and this doesn't happen for everybody, but in the latent phase, if it happens, the contractions continue. So they're still having contractions, but they aren't as painful and they may not even be perceived. Usually they're not having a lot of urge to push at this time. The contractions are pulling the muscle up behind the fetus, and the fetus is descending and rotating. In the active pushing phase, the fetus gets to the pelvic floor and triggers that bearing down reflex, and then they feel a strong urge to push and have involuntary pushing. Now, I want to talk about the cardinal movements, and we're going to try to act them out with our little doll, but the doll doesn't quite move exactly like a fetus does. So usually the head enters the pelvis in the oblique or transverse position, okay? Transverse or oblique, because that's the widest diameter is side to side. So the head, side to side, okay? The head flexes down onto the chest. The head, once the head is in the pelvis, the head actually rotates. The shoulders don't, the head rotates, because now the diameter that's widest is anterior posterior. So it rotates. So we go in this way, the head rotates. I'll make that head twist, okay? Head rotates to fit the AP diameter. So the neck turns for that. The head passes under the symphysis pubis and it extends. So at this point, you're going to have crowning. And then when the baby delivers, or when the head delivers, the head is going to extend out of the vagina. After the head's out of the vagina, the neck untwists. So let's take the baby out of this pelvis. Okay. Head twist. Okay. Baby goes in, head twist, head delivers, and then the head untwists. So when the head delivers, it usually immediately turns to the side. All right. When the head rotates, then the shoulders emerge. Usually the anterior delivers first, and then the posterior. Okay. So that's the cardinal state movements of labor. There's actually a video that's an animation of it. Please watch that. It'll help you get a good picture of what's going on. Because when you see that baby delivering, you really want to see the head come out and turn. If the head delivers and then turtles back in instead of turning, you're worried that the shoulders are stuck. Okay, so when the head delivers and then turns, it should be now lined up with the shoulders, anterior and posterior shoulder. Okay, so now we're going to talk about the third stage. The baby's out. Once the shoulders are out, the rest of the baby comes out. Okay. The third stage is from the birth of the fetus to the birth of the placenta. This is really fascinating. Remember how the placenta is made. The placenta is embedded into the wall of the uterus, and the blood vessels behind the placenta have been kind of eaten away so that they're just putting blood into that space under the placenta. Okay. So baby's out, the uterus keeps contracting, and it keeps contracting, and it keeps contracting, but now there's not a fetus there to prevent that contraction from making the uterus smaller. So as the uterus keeps contracting down, the placenta, we have a placenta. The placenta, which is on the wall of the uterus, it contracts and contracts and contracts, and it peels off. So when the placenta starts to peel off, we get some bleeding behind it, and that blood pushes more of the placenta off. So a few minutes after birth, it looks like the cord gets longer, because remember, this cord is just outside the vagina. That's what we can see. All this is happening inside. Okay. Cord gets longer, gush of blood. And that's because the placenta has released from the wall of the uterus, and the blood that was behind it is coming out. At that time, the patient should push a little bit. There's a little bit of voluntary pushing with contraction. Usually the provider is going to try to help that placenta deliver. We don't want to be tugging on the cord. You can actually invert the uterus if the placenta is still attached. Now, in the fourth stage, this is the really amazing part. You're thinking, we have peeled the placenta off the wall of the uterus, and all of those open vessels are pouring blood into the placenta, but it's not there anymore, and the placenta is not there to stop the blood. So now what happens? The uterine muscles are crisscross fibers. Okay. So after delivery, we want the uterus to contract down really tight, and those crisscross fibers cut off circulation to those vessels that are open to the placental bed. They're still going to have some bleeding, but we want them to, that clamp down prevents them from having life-threatening bleeding. So the uterus has to stay firmly contracted. This is the fourth stage, and it's the first 2 hours after delivery. The uterus has to stay firmly contracted to prevent hemorrhage, because we want to clamp off those vessels, and those vessels will go away eventually. They've just got to stay clamped off until they do. Okay, that you make new vessels, those ones that are open to the uterus are going to dry up and go away. Okay, so you're going to make new ones. Clamp off those vessels by keeping the uterus firm. Frequently, a med is given during this time period to keep the uterus firm. We want contractions to prevent that hemorrhage. At this time also, the fluids start shifting back where they belong. Remember how we have 150% of our normal blood volume during pregnancy. So blood volume increases by 50% in pregnancy. We get rid of a lot of that in the first couple hours after delivery. There's a big diuresis that happens. Now there can be some complications. Ms. Durant's going to talk about preeclampsia that can delay that, but normal healthy, a big diuresis happens usually in the first hour or two after birth. So they're going to need to pee really soon, within an hour usually. It is important because of all of the numbness and soreness from everything that's just happened. They might not have that sensation of needing to urinate. It's really important that we don't allow the bladder to get overfilled, because postpartum, a full bladder pushes the uterus up. Let's go back to our model. Now, our uterus is going to be much smaller, okay, and it needs to stay tight contracted. If the bladder's full, it pushes the uterus up and it prevents it from contracting effectively. So a full bladder can actually lead to postpartum hemorrhage. So we want to make sure that they're voiding frequently in that postpartum period, especially in that first, we want them to go within the first hour preferably, or we're assessing to see if their bladder's full. If the mother and infant are stable, we want to encourage breastfeeding if that's their plan, and bonding. We want to observe both of them closely for complications and for the effects of any anesthesia or analgesia. So they get really close observation in that first 1 to 2 hours of transition after birth. Okay, so we're going to talk next about what physiologically happens to the fetus and to the fetus in labor.